week's Journal Club. My name is David Eames. I'm a pediatric intern. The title of my Journal Club is A Day in the Life of and Emerging from the Shadows. I couldn't pick which one was more funny, so I just went with both. This is Buzz Lightyear and Woody from Toy Story for those Disney enthusiasts that are on. All right, here's the objectives, and just kind of diving right in. The journal article that I chose to do Journal Club on was an article published last month in Hospital Pediatrics, an AAP publication, and it's a study about nurse-resident reciprocal shadowing program aimed at improving interprofessional communication and collaboration. The study took place, it was a mixed method study investigating the effects of, like I said, a reciprocal shadowing experience between pediatric interns and clinical nurses at two large academic children's hospitals. That was C.S. Mott Children's Hospital at Michigan Medicine and Cincinnati Children's Hospital. It looked to evaluate interprofessional perceptions from various aspects of the work environment prior to, immediately following, and 6 to 12 months following the shadowing experience, where nurses shadowed interns and interns shadowed nurses. The main authors of this article were both from C.S. Mott, and the main physician author was Kimberly Monroe. She works at C.S. Mott Children's Hospital in Michigan. She's a pediatric hospitalist who instructs resident physicians and medical students. She earned her master's degree in healthcare quality and patient safety from Northwestern University and then went on to earn her medical degree in 2000 at Wayne State University School of Medicine. She then became a board-certified pediatrician after completing her residency training in 2003 at the University of Chicago. And her research interests and prior research experiences have all been in the areas of healthcare quality and patient safety, sepsis, family-centered rounds, newborn care, and infant-driven feeding. The next co-lead author was Jennifer Kelly. Ms. Kelly is a pediatric clinical nurse specialist at C.S. Mott Children's Hospital. And prior to her current position, which is sounds like it's probably administrative from what I found, she worked in a pediatric acute care medical surge unit for years, interacting with resident physicians and medical students. Her professional interests include finding new ways to improve communication between healthcare providers to provide high-quality, safe care to patients, and she has presented on multiple nursing topics, both at local and national level conferences. So the reason why this was done, as you can see from the title of the slide, is that every year in July we have groups of interns going through pediatric residency programs or coming into pediatric residency programs who have to work and collaborate and communicate with pediatric nurses in their daily work environment, and sometimes that doesn't always go well. So failed communication is the major contributing factor to most sentinel events in the hospital setting. Failed communication between team members is thought of to be a multifactorial issue that stems from multiple things, but is considered to stem from a lack of understanding of other team members' roles. And the researchers here aim to evaluate the effects of a reciprocal shadowing program on that to see if being able to walk a day in the life of somebody else's shoes could help improve communication and collaboration between the two professions. These were some interesting statistics that were listed in the article. Ineffective or insufficient communication has been linked to more than half of sentinel events submitted to the Joint Commission from 2004 to 2015. I think we've all probably heard it multiple times in our program that communication is the leading cause to sentinel events or poor patient outcomes in the hospital setting. Nurse-resident communication failures are common at academic institutions, and past research has suggested that These failures in communication may stem from differences in the level of training, leading to different comfort levels with various communication styles. And then also some interesting points on this is that with the evolution of technology and secure texting apps like PerfectServe and electronic health records, there's been a decrease in face-to-face communication, which has led to suboptimal communication happening between nursing staff and the rest of the medical team. Less than optimal communication can lead to poor understanding or various team members' roles, interprofessional collaboration, and worse interprofessional relationships. So if you can't talk to the people you're working with, it kind of goes without saying that things aren't going to go well with what it is you're working on. And in our case, we're working on patients' lives, so that's kind of the utmost importance. Shadowing programs in the past have shown improved interprofessional relationships and collaboration opportunities where they've been implemented, but not a lot of research has been done to look at shadowing programs with nurses and residents being afforded the opportunity to shadow their immediate counterparts, especially in the setting of where they're actually working. So I know a lot of us do shadowing opportunities throughout our training coming up, but we don't then go back to usually work in those same places. So if you can shadow your immediate counterparts, that's something that these researchers wanted to see if that had a benefit to the outcomes here. So this study was a multi-center study, took place at CS Mont Children's Hospital, which is a 250-bed children's hospital with over 2,000 admissions annually. The study took place in this hospital on their 32-bed acute care unit. Nursing participation here at CS Mont was voluntary, but the interns were mandated to take part of it as part of their professional development week. Of note, one of the interesting facts I also saw in there, though, was that at CS Mont there was an incentive provided for participation. I think it was like a nominal $5 gift card for each survey submitted. Whereas at Cincinnati Children's Hospital, that's a 600-bed children's hospital with over 7,000 admissions annually. The study took place also in their acute care unit, but their acute care unit's a little bit larger. The existing unit nurses could volunteer to participate in this, whereas their newly hired nurses were required to participate as part of their orientation. The interns, again, were mandated to participate. This was part of their required ambulatory medicine rotation. So taking a look here at the participants, some interesting things that I picked up on was that Cincinnati Children's actually had better nursing participation even among just the solely like volunteer participants, despite not offering an incentive, which I'm not sure how to explain that away, but it was just interesting to me. If you look here, I don't know if you guys can see my cursor, but Site 2 is Cincinnati Children's. They had 25 total nursing participants, but 13 of those were with more than 1 year experience. So I was estimating there that meant that those were existing unit nurses that were able to volunteer. As we mentioned, that the existing unit nurses at Cincinnati Children's were able to volunteer, and they weren't mandated to participate in this. But at the resident side, all the interns were mandated to participate. Excuse me. So this, again, is a very recent study. It was just published last month in Hospital Pediatrics, but the study took place during the 2018 to 2019 academic year, which runs from July to August, kind of mirroring ours. So to me, that kind of amplifies the relevance of the study by its recentness. These interns that participated in this study are actually the third-year seniors in their programs now. And more than likely, a lot of those nurses are still the same nurses that they're working with. So the biggest weakness to this study is obviously its power, considering it's kind of limited by its nature and the number of participants that took place in it. seeing as how it was only done at 2 different hospitals, but that kind of limits its power. But it's kind of uniquely strengthened by this, too, because it was able to look at that one intern year, and then because they progressively used these surveys going on throughout time, it was able to follow those same working relationships, if you would. So this was a mixed method study, which I was not too familiar with. I had to do some reading on. But what a mixed method study is it's a study that kind of originated in the social sciences, but has kind of been extrapolated to medicine, and especially in the healthcare setting. Is doing a lot of studies this way now. But the researchers kind of collect and analyze both quantitative and qualitative data, providing both types of results to kind of weigh on their drawn conclusions. So as opposed to just asking scaled questions with responses like with an option strongly agree, strongly disagree, and the spectrum in between, it also affords the opportunity to provide free response style answers. So oftentimes these studies implement data extrapolated from participant surveys, utilizing specific questions with scaled responses as well as short answer free responses. Kind of the advantages to this type of a study is that it includes the subject's actual feelings and provides a more accurate impression of the participant's impression versus the scaled survey questions. I put this little bit down underneath, like how many times have we all filled out one of those surveys and then just thought to ourselves, like, well, that's my answer for that question, but if it had actually asked me the question I wanted to be asked, then this would have been my answer. So that's kind of like bypasses that, which I think is pretty unique to this type of study. But I think that lends to its strength in the way that it allows the two populations to really express how they feel, as well as, bringing them together as the end goal of the study. But one of the limits put in place by this is that it kind of limits the blindness, because the free responses obviously can sometimes be interpreted as to who submitted them, but it can also, in order to kind of combine and analyze that qualitative data, you have to take all the collected information back to the group. You'll see how they kind of went forward with this study. So in this specific study, interns and nurses participated in a reciprocal 4-hour shadowing experience. And they completed an anonymous online survey, only identified by their clinical role and their location, so which one of the 2 sites they were at. And the surveys were conducted prior to, immediately following, and 6 to 12 months following the shadowing experience. The surveys included, like I said, both quantitative survey questions with scaled numeric responses that were analyzed on like linear models, and then the surveys also included qualitative free response questions that were analyzed and grouped thematically, and we'll get into those in a little while, how they did that. The participants were only included in the study if they completed the intervention of shadowing and then responded with at least one of the surveys. So the quantitative methods that they used here for their scaled response questions was derived from the Interprofessional Collaborative Competency Attainment Survey, which is a retrospective pre- and post-survey tool with good validity evidence used to assess interprofessional collaborative competency prior to and after an intervention is made. It's a 20-question tool that utilizes participants to kind of self-assess their skills in 6 different domains. Those domains include communication, collaboration, roles and responsibilities, collaborative patient and family-centered approach, conflict management and resolution, and team functioning. So within these 6 different domains, the participants were given questions, and those questions had a scale of, I believe, 1 through 7, where they could either strongly agree, strongly disagree, and everywhere in between. And they were asked to assess their own competency in these different domains. When it comes to the qualitative methods, the qualitative portion of the survey included open-ended questions derived from those 6 different domains of the ICCAS. These responses were reviewed by study administration, so 3 people, and grouped by respondent role, so nurses versus interns. And all responses were then thematically coded by each administrator, and all codes were revised through peer debriefing. The codes were combined into categories and main themes, and then the themes were reviewed with 2 to 4 residents and nurses, study participants from each site. So they kind of collected all the different free responses, grouped them into, well, this response falls under this theme or this category or this domain, and then they went back and kind of broke those down to kind of sub-themes, and then went back and used some direct quotes from those pre-responses and presented that to the 2 to 4 resident nurse panels and asked if they were reflective of their experience with the shadowing and pre and post perspectives. So some of the results. The goal of this study was to identify whether or not this shadowing experience could improve nurse-resident communication, as well as this is something that both of these institutions had identified as areas for potential improvement. I do feel like, and the researchers did feel like this goal was met and supported by the study's findings. Both nurses and interns showed statistically significant improved scores in all 6 domains, from the pre-shadowing survey to the immediate post-shadowing survey. And then there was also improvement from the pre-shadowing survey to the delayed post-shadowing survey, implying that there is sustainability of the improvement that was seen. So this is kind of the graphed way that a lot of this was portrayed. So each one of these graphs, as you see, kind of go in this manner, up and down. This is the different domains where the questions were asked. So this is actually COM1, COM2, COM3, and COM4 are reflective, and COM5 are reflective of the 5 different questions that were asked in the communication domain. And then this top line going across here is the nurses' responses, and this is the residents' or interns' responses down here on the bottom part. And then this second half of the graphs is other domains. But some of the interesting stuff that I thought was evident by this depiction of the results is that you do see more clinical or clinically significant improvement under the residents or the interns surveys than you do on the nursing in most domains. But I wasn't sure if maybe that could be confounded by the fact that as time progressed throughout their intern year, they just became more competent residents. But that may also be suggested against, seeing as how there was clinically significant improvement immediately prior to and immediately following the shadowing experience. So each one of these 3 bars in each one of these things stands for the pre-shadowing survey. The middle bar of the groups of 3 is the immediate post-shadowing survey, and then the third and final is the, delayed post-shadowing surveys. So each one of these different graphs is for each one of the questions, and then the whiskers on the bars are actually standard deviations is what they're representative of. But the brackets with the asterisks over the middle of them are to show you where there was statistical improvement from pre-shadowing to after shadowing, or even the delayed after shadowing survey. So the wider bracket with the asterisks over top of it suggested that improvement is sustainable, whereas the narrower bracket with the asterisks over top suggests that it's one of the ones that's immediately post-shadowing responses where there was improvement. We can go through the rest and then kind of come back to that and review some of what the actual specific questions were surrounding these different bar graphs. So some of the qualitative results were broken down, like I said, into themes and then sub-themes for identified responses, but overall showed improvement under all of the different themes here for effective communication, collaboration, patient-centered outcomes, role understanding, and team process. So there's some of these sub-themes were areas where specific quotes were picked up and kind of broken down into that. We can, again, go through the rest of this and then kind of come back and touch on the specifics of those. So conclusions drawn by the authors is that the shadowing experience did significantly improve the participants' assessments of their interprofessional collaboration and communication, which plays a crucial role in situational awareness. That middle bullet there, not sure how that kind of came through. It's not supposed to be there. There's nothing missing from the slide there. And then these findings did, strengthen the interprofessional working relationships, and that may lead to improvements in quality of care for the patients and their safety. So one of the things that I kind of identified as a goal for future studies after reading this is that maybe future studies could aim to identify whether or not patients are able to appreciate any difference translated to them via the care they receive or the instruction provided from various providers during their admission, or by looking at the patient outcomes or satisfaction surveys prior to implementing a shadowing program and then after implementing a shadowing program. So to kind of go back, and I want to touch on these if I have time. I'll go through the ones that showed specifically sustainable improvement here, and I'll just read off kind of the survey questions. So the first one, communication 1, did show significant improvement that was also sustainable for the residents, and that's the specific questions was to how do you feel, or what is rate your capability of promoting effective communication among members of an interprofessional team? So in that area, there was statistically significant and sustained improvement for the residents. However, there was not any for the nursing staff. And again, communication 2 showed the same significantly improved and sustainable results, and that was for them to assess their ability to actively listen to interprofessional team members' ideas and concerns. And then for the communication domain, the one question that did show resident and nursing significant improvement that was sustainable is for them to rate their ability to provide constructive feedback to interprofessional team members. So both residents or interns and nursing staff felt more comfortable immediately following and 6 to 12 months after the shadowing experience to provide constructive feedback to each other. Just in the interest of time, I'm only going to review the ones that did show statistically significant improvement that was sustainable. So under the collaboration domain, there was those findings where they were able to assess how they work effectively with interprofessional team members to enhance care, as well as rating their ability to learn with, from, and about interprofessional team members to enhance care for the patients. Under the roles and responsibilities, the one question that did show significant and sustainable improvement was them rating how they are able to recognize others' skills and knowledge and complement and overlap with their own. There was statistical sustainable improvement noted for the residents in the collaborative patient and family-centered approach, but not for the nurses, so I won't review any of those ones. That same result was in conflict management and resolution, but in the team functioning, there was improvement that was sustainable in both groups, residents and nurses, ability to negotiate responsibilities within overlapping scopes of practice. So that was some of the sustainable ones that were statistically significant. And then as far as the qualitative findings, I wanted to read just some findings from the study. It says, after shadowing, nurses and residents described feeling more empowered to raise concerns, ask questions, and share opinions with each other. One nurse stated that after shadowing, she felt more confident in sharing my opinions as the team made it clear that our input is needed. That was under the communication theme. For collaboration, that theme, a resident noted that the intervention formed a bond with a nurse that I could go to with issues and vice versa. And participants further identified trust as a key element in collaborating with each other and with patients and families after the shadowing experience. As far as the theme of role understanding, after shadowing, numerous residents reflected that nurses spend more time in patient rooms, noting that information nurses gather from those interactions supports developing optimal plans for the patient and family. Both respondent groups appreciated the opportunity to shadow and learn more about each other's responsibilities, noting that there is sometimes a lack of understanding when it comes to respective roles and what they include. Nurses commented on appreciation for how busy the interns and physicians actually stay throughout the day. As far as the team process theme, one resident commented, physician and nursing workflows are very different, so quick response time is challenging if a nurse is feeding a baby or if a physician is actively rounding on another patient and unable to be at bedside. It is helpful for us to understand the other's perspective and workflow by shadowing. So after having gone over those, I guess the question I want to pose to start and lead off some conversation about this study is, what are your thoughts about the study, and then what thoughts or feelings do people have about conducting a similar study at Carilion? So we have in the room a comment about willing participation from participants from both sides. So certainly finding people who would be willing to participate in this. I think we could go about it in a way of, if somebody wanted to do this, you could go about it in a way of having interns do it like both of these children's hospitals did. I think that was a good, unique approach that they took there to kind of mandate some participation from the resident side, but also allow for it time-wise because it is something that's mandated in their training at these two different institutions.
Hey, this is Dr. Ward. Can you hear me?
Yes.
Yeah, so interesting article. I think in terms of, when we do these journal clubs, there's kind of these, and this is an evolving field, but you kind of have these two types of studies. You have qualitative studies and you have quantitative studies. And this is as a whole is a QI project for the most part, right? They're working on improving communication with their intervention. And the QI projects don't get as much scrutiny and, looking through the issues with their methods and stuff that a lot of the, the quantitative studies get. Now, they did word of their data about quantitative in there, but as a whole, this is kind of a QI project for the most part. If we were going, and with saying that, one of the things with QI projects is, and one of their limitations is the external validity for them. So it may work for one institution, but it's harder for those to necessarily work for another, and it may not be a good fit. And so that's how I've kind of looked at this project to look at how they went about it. I wanted to see with what your thoughts were on the methods section when they did their pre-survey. So if you think about this, in July, you have the intern class coming in. When is a good time to actually do the pre-survey? If you do it too soon, then perhaps they don't have enough, working experience to be thoughtful enough to answer, I guess, accurately, right? And then if you just do it right away, but then what do you wait 6 months or so, or do you wait a couple months? And so did you see where they really talked about that at all, or and what
So
would be your thoughts of when would be a good time to do that?
that was another thing that I kind of wondered about, the validity of their results and being able to transfer it to a different facility because of that. So they didn't really describe at what point in time during the year they did that. So I was kind of left the reader to guess, did this happen? They mentioned it happening during a mandated rotation for the interns, but was that mandated rotation of ambulatory care and professional development, was that in the first 6 months of their training? Was it in the second 6 months of their training? It didn't really let you know that, so that it kind of would skew the findings there, I feel like, because you're dealing with two different levels of interns at that point. One that's, brand new and very green to the work environment, and then whereas if you do it in the latter half of the intern year, you're kind of you're using interns who have more experience and maybe have gained impressions by that point. So the only way to improve the validity of the results, I think, that I came up with was thinking about doing it over the course of 2 years. So providing a survey, a pre-shadowing survey to classes who had not done the shadowing intervention, and then comparing those results to a different intern class, maybe a year down the road after they had done it. So at the same level of training, when the interns who went through the shadowing experience got to the point of interns who didn't, or second years by that point who didn't, offering them the same survey question again. So it's okay. Again, kind of apples to oranges, but I don't know of a better way to do it.
Yeah, I might would have approached it to you don't even have a survey. You just do the intervention, and then maybe you're not using the questions they use. You may shape it a little bit differently. But I think it was very reasonable what they did. It was very well put together. As you had mentioned, I didn't realize it was good that you put the background on the author. She actually it looks like she's got a master's in QI, which is kind of a new evolving field to do that. And so I could tell that it was flavored a little bit towards someone who has some statistical training and doing the chi-square testing with some of these things, because you don't see that as often in some of these QI journals and QI projects that they're doing that. So I thought that was interesting. And then another part of, I think I was going to mention, some of the conflict stuff came up in looking at what was statistically significant. It was for the residents. It looked like there was an improvement, but not so much for the nursing. And I don't know if that's just you may need more than just this intervention to really grow conflict management skills amongst all of the staff. And you just may need a more of a robust approach with that, because that's a tough one. It's like, it's hard to build up, but then it's kind of easy to just tear it apart or have issues at conflict amongst the clinical team. And then the other thing with this questionnaire, I thought it was a little lengthy. 20 questions would be another limitation, and then your return rate. So maybe perhaps that being simpler. If you're looking at table 2, this is the survey response rate. You've got your different sites, and am I reading it right when I see that you've got kind of site 1, site 2, 8 responses, 8 participants, and then it dwindles down with their percentile return at 6 months, 29% return to survey, 64%, and then that's amongst the nursing. And then you're in the 40s and 30s for the resident. Am I reading that right?
Sorry, I was navigating to that table.
Yeah.
Could you repeat just the last half of your question?
So I'm questioning if they had good response rate.
So the response rate did significantly drop off to the 6-month post-shadowing survey from what I saw.
So you're seeing 29% returned in at site 1 with the nurses, and then 64%. Site 2 really stepped up as compared to the residents. Residents were kind of in the 40s and 30s with their percentile of return rate at 6 months. So that's fairly poor, right?
Right.
And so you'd have to look into what, if you were going to design a study, what would be a better way to return your responses. And it could be that one thing could be is just using that Canadian communication tool, that 20 questions, 7-part Likert scale deal may have just been a little too cumbersome to get a response on. And could they have made this simpler and perhaps gotten a better response rate? But you're missing a fair amount of patients, and perhaps there's some bias there, your response bias, right? So you could have people who are more likely to respond and have positive responses. They're maybe the more type A personality folks who are responding, and they have certain answers where you're missing, like at site 1, you're missing 70% of your nurses, and maybe they had something negative to say, and they just didn't respond. So you want to try it.
Which I thought was interesting, because that's kind of where the site 1, which was CS-Mont, that's kind of where the whole study was headed up. But Cincinnati Children's definitely offered more responses and better participation. Yeah,
that is interesting I think it has to be, you've got to have someone within the institution, I guess, to really flavor it. But yet they did, and they didn't get great response on it. I'm trying to think of anything else of other limitations to it. I mean, there's a lot of things that could be argued with these types of QI studies, but you kind of can use this of how do you see how they did something, and then can you pick and choose a few pieces of their study and flavor it to your own institution to make a pretty good project that fits.
Yeah, absolutely.
Yeah, sorry, Dave Finkler here. I would agree with everything, and thank you, Dr. Eames, for bringing this up, and Dr. Ward for chiming in. I mean, and I'd also agree. I mean, I think in terms of QI studies, I think that this one certainly being mixed methods, I thought that they did a decent job of trying to make it as robust as they could. I mean, a lot of times when you're reliant on survey data, things can get a little tough to draw out meaningful conclusions. But I mean, I'm very curious to hear what other people's opinion is of whether just seeing the study and thinking about it, whether they felt like this would be a good thing or not to consider trying here. I mean, my own bias is that even if the results of the study had said the opposite, it seems like such a meaningful and well-intentioned approach, right? Just speaking for myself, I know that anytime that I get to know another field or individual's own workload better, I have a much better understanding about what their role is and about some of the things they struggle and face. And I feel like that kind of sort of multidisciplinary understanding is always helpful in our medical teams. So I don't know, curious to see what other people think. You go back in time and have this as part of your intern orientation, would you have wanted that?
Specifically me, which I don't like to speak for large groups, but yes, I would. I think I would have appreciated it. I don't know that in the immediate sense I would have kind of gleaned the benefit of it, but I think down the road the benefits definitely would outweigh the cons to it here in a situation where you're just going to become more familiar with your coworkers than anything. Kind of leaning to what you were saying is, like, anytime you understand a different aspect of the healthcare system, it lends like more sympathy or empathy to them. It's always better to have seen what's actually coming through from the nurse's perspective as opposed to just what's going on from the resident's perspective in terms of being able to communicate and work efficiently together. So I think personally I would have liked to have done it. I think that I still would be able to do it, even if it wasn't just from an intern's perspective, if it was from even senior residents' perspective, because I still don't think, even coming to a close on intern year, that I have a great appreciation or understanding for how the workflow happens from nursing standpoint.
thanks. This is Emily Wynn. So I had this in residency, and it was mandatory during one of our ward months. And it was primarily during a day shift, and then the nurses would shadow us as well, also during a day shift, but I think it was towards the end of the day. And I don't know if this is as much a comment on this study in particular, but I thought it was really helpful just in figuring out and understanding the roles of nurses a little bit better. Up until that point, I had absolutely no idea how much nurses had to document and how much they had to input on the computer, and how, I just had no idea until I actually saw it and shadowed. And I think in particular, we're so siloed in our own respective roles within healthcare that there's a lot that probably each party or each role doesn't necessarily understand about other roles. And with how interdisciplinary medicine really is, I think having a better understanding of other roles and what the day-to-day is, I think can only be a good thing. I think all of us know generally what other healthcare members do, but actually having a more specific, more detailed look at kind of the day-to-day functions, I think can only, in my mind at least, help with at least the communication or better understanding, and also just helps know who different team members are within your department.
Yeah, I agree, Dr. Wynn. This is Andrew Miller. I guess I had two thoughts related to this. One, I think it would be a great thing to implement. It's certainly, we talk about risks and benefits. There's really no risk to making people do this. It certainly has the potential to be helpful. I do think, and this will kind of lead into my second comment too, some of the things that seem like they would intuitively be helpful may not always be that way. I think the leap from putting yourself in someone else's shoes to the actual increase in emotional intelligence and change of behaviors and how you interact with someone is quite a big leap sometimes. And so I think a lot of times these studies, while it may seem logical that if I know someone else's shoes, it will therefore make me change my behavior, that's not always the case. And we see that with medical students, requiring them to do ethical courses, and yet they end up having unethical behaviors because the knowledge aspect doesn't always translate to a change of behavior very easily. So I think we have to keep that in mind. And kind of in a similar vein, good intentioned ideas not always being helpful. In Eames, I don't know if you came across this in any of your literature, but there are a lot of other interventions we do under the guise of being helpful, such as implementing perfect serve. And we kind of live under this presupposition that if we increase communication, that things will improve. But I'm curious if you came across any literature or anything that shows that some of these things that we think would help, do they really help? Or, is the perfect serve just using that kind of as a scapegoat here? Is that just more burdensome and actually it maybe doesn't help in the ways we think it might?
So what I found,
sorry, I was
maybe,
just going to say, my guess is that you may not see some of those studies just because of the lack of data or conclusions. It's not as easily published. But sorry, go ahead,
right,
David.
And Dr. Miller, I'm sure that there is good data out there to suggest that perfect serve is helpful and useful. However, from this aspect of when I was doing my reading, everything that I found in literature from looking at communication being improved and collaboration being improved suggested that secure text messaging apps and phone call apps such as Perfect Serve actually deteriorated the level of communication between coworkers.
I'm sure there's plenty of folks that would not find that overly surprised. Andrew, thanks for, I loved hearing your comments. Yeah, I think that, and a lot of the interventions that we do to try to improve some of the EQ and social norms and behavior, especially, and people are tough and difficult to achieve those goals. But yeah, I mean, I think that at least one can hope, right?
Yeah. Hey, this is Dr. Ward. So Andrew, what are ways to address those things you mentioned, like with the medical ethics study with the students? What are ways to change behavior that is not accepted?
That's a fantastic question. I think if any of us find the answer to that, we'll probably make a whole lot of money in a short period of time. But, you know, it's been interesting. I did a short kind of dive into this recently, and it turns out, especially related to patients, trying to convince them to change their behaviors, at least in pediatrics, the literature shows that very little, if anything, actually changes their behaviors. You can tie it to all sorts of things. I think financial incentives have shown to be one of the most important things in changing behavior, for better, for worse. I think a lot of times it comes down to kind of the ethos with which you operate. And if you're, no matter who you ascribe to, Plato, or if you're Aristotelian or something different, I think the bedrock on which how we interact human beings is built so deeply that it really requires a pretty deep change in order to change that behavior. I think that the types of studies we're talking about that are really working at a more surface level are certainly helpful. And you hear kind of anecdotal stories, right? You have the youth group kid who went to another country and saw how they lived, and it completely changed their life. And so it's not that these surface level interventions can't change people's behaviors. And like I said, there's certainly not a lot of harm to them. But I think we have to have limited expectations in terms of how, they're not going to change everyone's attitudes and how they interact with others. I think that, like Dr. Finkler was kind of hitting at earlier, to change the culture the culture of an entire organization is a very deep kind of quagmire sort of problem to deal with, and it requires interventions at a myriad of levels. So it requires you to have the interns interact with the nurses in a program like this. I think it requires having senior leadership act in a particular way, all the way up to like hospital CEOs, and how we structure the organization, its incentives, and those sorts of things. It doesn't mean that we can't start at each individual piece of the puzzle, and I think that a study like this could be helpful. But I think to really get at culture change, just like if you're trying to solve any other major issue, global warming, insurance, whatever, it really takes a lot of different interventions targeted at different people groups in different walks of life in different areas to make that sort of effective change.
Yeah, that's well put. I would agree with that. Certainly in medicine, attending wise and changing practices, if there's laws against something, legally change. And then you mentioned financial incentive. And it's kind of worded amongst a lot of the communication literature with rapport building, but it's actually, having that shared goals and shared values is at least some of the start. And but I agree, it's not, it seems to be pretty challenging. I'm working on this communication project. And it's and part of it is being able to measure things. That's what we've found it to be challenging. How do you measure how well we communicate, or where some of the deficiencies are? But through some of my reading, that was some similar themes were coming up from what you were mentioning.
Certainly don't want to discourage people from trying a project like this. I think someone said it once well to me, in a different problem dealing with like waste in the environment. We don't need one person doing it perfectly. We need everyone trying their best and doing it as a result of being humans imperfectly. I think if we take that same approach to our attitudes with communication, it's not that we can't have breakdowns sometimes and treat someone meanly. It's that we as imperfect human beings need to then find ways when we communicate with each other to dig into some of these deep, emotional intelligence things like forgiveness and being able to ask for that, and being able to put ourselves in other people's shoes. And I think a study like this and an implementation of this sort of shadowing program helps chip away at some of those things, and is a great starting point, as opposed to just throwing up our hands and saying, well, these traditional stereotypes and norms which have existed for so long will exist forever. We got to start somewhere. I think this is a great spot.
I'm getting the cue that I think that is kind of our time limit and wraps up Journal Club for this week's iteration of it. But thank you all for your input and discussion at the end.